Okay, good evening and good afternoon, everybody. Thank you for calling in. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at Ovarian Cancer Research Fund. I want to thank you all for joining us today as we continue our webinar series for 2012. This entire webinar series has been supported by Genentech, and we want to thank them for the generosity in making these all possible. OCRF is the largest organization in the U.S. devoted exclusively to funding ovarian cancer research. Our mission is to fund scientific research that leads to more effective identification, treatment, and ultimately a cure for ovarian cancer. Since we made our first grant in 1998, we've awarded nearly $45 million in research grants, and that number is going up every year. Before we get started, just a few housekeeping notes. All listeners will be in listen-only mode throughout the presentation. We will have some time for questions after Dr. Brewer's presentation. So if you think of a question as you're listening, you can type it into the Q&A box that you can see on the right-hand side of your screen. Now, nobody else will be able to see the questions that you ask, and you won't be able to see anybody else's questions, but I will be able to see them all. And there's no need to wait until the presentation is over to submit your questions. I do ask that you try to keep your questions as general as possible so that the answers will be useful to everybody who's listening. And after the presentation is over, I'll pick some questions for Dr. Brewer to answer. We're very fortunate and pleased to have the accomplished Dr. Molly Brewer with us today to talk about palliative care and ovarian cancer. Dr. Brewer is the Director of the Division of Gynecologic Oncology, Director of the Women's Cancer Prevention Program, and a Professor of Obstetrics and Gynecology at the NAIG Comprehensive Cancer Center at the University of Connecticut Health Center. Prior to these positions, she held leadership positions at Arizona Cancer Center at the University of Arizona in Tucson and the University of Texas Houston Medical School. She earned her medical degrees from the College of Medicine at the University of New York at Syracuse and completed her residency at Oregon Health Sciences in Portland and a fellowship at MD Anderson Cancer Center in Houston. And importantly, she's also a member of OCRF's Scientific Advisory Committee, and in that role, she generously donates many hours of her time to this cause every year. So, Dr. Brewer, we will now pass the mic over to you, and you can begin your presentation when you're ready.
Great. Thank you so much, Sarah. And I just wanted to welcome everyone who's joining into the webinar. This was an idea that actually Sarah came up with because she asked me about 6 weeks ago if I would be willing to give a webinar on some of the new things that are being done for recurrent ovarian cancer. And I said, you know, I can't, at least not right now, because I'm studying for my palliative care boards. And she emailed me back and she said, why don't we do palliative care? And I said, great idea. So just to let you know a little bit about myself, I'm a gynecologic oncologist. I take care of women with ovarian cancer. I operate on them. I give them chemotherapy. I watch them during their surveillance. And then if they recur, I take care of them at that point. I take care of them as long as they want to be treated. I have done, at least in my background, we've done a lot of palliative care as gynecologic oncologists. And so this was the last year that we could actually be grandfathered in to take the board exam. So that would, to be boarded in palliative care, you actually have to pass a fairly comprehensive exam. So that's really what we're going to talk about tonight, is what's the role of palliative care and why do we talk about it with ovarian cancer. Now, I have no conflicts of interest, just so you know. I don't work for any of the people that have anything involved with palliative care. So I put together with Sarah some of the objectives. We really want you to understand what palliative care is because there's a lot of misunderstandings about palliative care. How can it be incorporated into care for women with ovarian cancer? When should a woman with ovarian cancer consider seeking palliative care? And how's the best way to access palliative care, because it's not something that everyone does. And what can it do for you? You know, it's one of those why bother? Why should this be a part of your treatment regimen? So palliative care is really given throughout a patient's experience with cancer. It should begin at diagnosis, and it should continue through treatment, follow-up care, and if our treatment is not successful, it actually then transitions into the end-of-life care. And one of the things that people often confuse it with is they confuse it with giving up. I've had patients tell me it's, really that you're allowing my mother or my loved one to die. You're euthanizing them. Many patients and families perceive that their physician has given up on them. And one of the things about patients with cancer and their families is they need to know that their oncologist is their advocate. And so palliative care gets really perceived as being, you're no longer going to take care of me. Most physicians have traditionally concentrated on trying to cure patients, and they haven't really concentrated on symptom control. We do a lot of that, but it hasn't been our focus. And that's part of why, if you go to your oncologist and you talk about palliative care, they may or may not be receptive. This really is a new field. And I think one of the things to understand is more and more oncologists are actually seeking board certification in palliative care, because many of us feel we can take better care of our patients all the way through their treatment, from diagnosis through treatment, and then, when they go into surveillance, hopefully, there's a lot of symptoms that we can control. So what is palliative care? It's considered to be an area, it's a relatively new area of healthcare. It really focuses on relieving and preventing suffering. It's appropriate for patients in all disease stages, and it actually is for more than just cancer patients. Anyone who has a chronic disease is eligible or is appropriate for palliative care. Even those who are undergoing treatment for a curable disease. Many times our treatment of disease causes significant side effects, and palliative care can actually help really maximize your well-being and minimize those side effects. Anyone living with chronic diseases, and one of the things that we now know about ovary cancer is for many women this has become a chronic disease. That's the good news and the bad news. The good news is women are not dying as quickly. The bad news is they live with their disease for a long time. And so part of what, as oncologists, we need to do, we really need to be careful that we manage their symptoms. Most of us feel it should be available to all patients, to all cancer patients. And this is not the same as hospice care. That's one of the things that people become confused about. They think that hospice care is you're not going to be treated anymore. Hospice care does include palliative care, but it's not, they're not one and the same, and I'll try to go into a little more detail of that. Typically, this is a multidisciplinary approach to patient care. Currently, if you have an oncologist, you do have multidisciplinary care. You usually have nurses who manage some of the side effects associated with chemotherapy. You have pharmacists that are involved in the chemotherapy doses and mixing your drugs. But this also includes additional nurses who have expertise in palliative care, chaplains, social workers. It may include psychologists. It may include other health professionals. And they really all participate in formulating a plan of care. And the goal is to relieve suffering for patients, relieve side effects. It focuses on the patient and their goals. And that's an important thing, because sometimes a physician will have one goal and a patient actually will have a very different goal. And so part of what we are learning now as oncologists who are involved in palliative care is that it's important to talk to the patient about what their goals are. Sometimes I have a woman who I'm taking care of right now who said to me, I need to stay alive so I can see my daughter married. And she says to me, I know you're not going to cure me because my cancer's come back, but I need to stay alive. And so that makes it really focused for me, because I'm going to do my best to keep her alive and to minimize her side effects. And who does palliative care? I alluded to this a little bit. Previously, there was board certification through the American Board of Hospice and Palliative Care, and this is part of where hospice and palliative care became synonymous. Most recently, there's been a change, and there are actually 11 specialty boards, and it's through the American Board of Medical Specialties that you can seek approval. And gynecologic oncology has been approved to sit for palliative care boards through the Society of Gynecologic Oncology, and also through the American Board of OBGYN. We also have APRNs, or advanced practice nurses, who are board certified through nursing societies. Many times the APRNs are the ones that have a lot of patient contact. Much of the time they will manage the pain control and the symptom management with the help of the physician. So what are the goals? Provide relief from pain. One of the things that many women with ovarian cancer have is they have pain. They have shortness of breath. They have nausea. They have other symptoms that interfere with their quality of life. It's not intended to hasten death. It's not intended to postpone death necessarily, but it really is focused on controlling symptoms. It's also focused on integrating psychological and spiritual aspects into patient care. You know, as an oncologist, part of what I focus on is taking care of my patient. The psychological and spiritual aspects really are managed through my team. And I have a team that actually has a lot of expertise in palliative care. And so they will really focus on some of these things. Again, it's a team approach. This is a support system, and it's intended to help patients live as actively as possible for as long as possible. It sustains and rehabilitates the individual's families. You know, one of the things that I've been impressed with is we have a support group for women with gynecologic cancers, and most of the people in there are patients with ovarian cancer. The spouses, the children, it's very hard on them, and so this actually helps support the individual's family. It's meant to enhance quality of life. It's applicable early. It's applicable in conjunction with other therapies, and we actually sometimes use chemotherapy or radiation to relieve symptoms, and it certainly is compatible with treating symptoms and also treating disease. We also try to minimize hospitalization. Women don't want to come in the hospital. They spend enough time in the hospital. And so if we can treat them adequately and keep them home, keep their symptoms under control, support their family, then this is one of the things that patients tell me is important. So I kind of put together a little bit on what are the differences between palliative care and hospice care. They share similar goals. They both intend to provide symptom relief and pain management. But palliative care services are offered to any patient. There's no restrictions. You don't have to be a patient with a poor prognosis. It really applies to any patients with a disease that's being treated. It's appropriate for anyone with a serious or complex illness. And as you know, ovarian cancer is a very serious and very complex illness. It doesn't matter whether they're expected to recover or whether they live with a chronic disease. It can be for an extended period of time, or it can be until their disease progresses. Some patients at some point with ovarian cancer often opt to go into hospice. Hospice is really a different thing. Hospice care requires two physicians to certify that a patient has less than 6 months to live if the disease follows its usual course. It doesn't mean that if they survive after 6 months that they have to leave hospice, but this is very different. Anyone can seek palliative care services, but hospice care, it has to be certified by two physicians. And I just thought I'd talk a little bit about the Medicare hospice benefit, just not to talk so much about hospice care, but so those patients who decide they want to enter hospice, they actually sign off of Medicare Part B, and they can enroll through direct care into a certified hospice agency. Under these terms, the hospice agency is responsible for the plan of care, and the patient is not billed for these services. This is one of the things that I learned about palliative care is there's a very well-funded mechanism for these patients. And the hospice agency, together with the patient's primary care physician, determine the plan of care. So it really, again, it's a team approach. Sometimes a patient enters hospice care because they're not doing well. They can withdraw from it. If there's a clinical trial that they want to go on, they can withdraw from hospice care and enter it later if they so choose to. So palliative care, now we're going to go back to palliative care. I just wanted to put that in there because a lot of people don't understand the difference. How is it reimbursed? It's reimbursed in multiple ways. It can be paid for by philanthropy. Many of the cancer centers are starting palliative care programs. And they are funded oftentimes by philanthropy as they're really getting up and going. It can be a fee-for-service mechanism depending on insurance. It can be direct hospital support. Hospice care is provided as a Medicare benefit, so it's a little bit different. Most Medicaid and private insurances will also cover some aspect of palliative care as well as hospice care. So why is it something that we're talking about? It's actually really important, I think, for many ovarian cancer patients and for their family to have some help. It really helps with pain management. Sometimes what happens is after surgery, a patient goes home, they're given pain medications, they don't work. There's not necessarily someone who is on call 24 hours a day if a patient has pain. So the patient then comes back into the emergency room. Palliative care will keep patients home. There's usually palliative care team members that are available. They can help with pain management. The other thing that they can help with is things like bowel obstructions and ascites. You know, much of the time these can be managed in a non-surgical way. They can help with the emotional and psychological and spiritual concerns that many patients and their families have. They're involved in care planning. And the other key thing, and this is one of the things that was really focused when I was studying for my palliative care boards, palliative care requires that the care plan be concordant with the patient's wishes. And again, it's something that we really need to sit down and talk to patients about. Talk to patients and their families. What are your expectations and what do you want? When should a patient start receiving palliative care? It can be at any time. It really should be part of the management plan. And this is a new thing. So again, if you talk to your oncologist about palliative care, this is a field that is really very young. But what I'm hoping is that it will become part of our standard of care. Surgery for ovarian cancer is usually associated with many adverse side effects. These are managed by your surgeon, and oftentimes your surgeon and the person who's giving you chemotherapy are the same person, or it may be your medical oncologist. Chemotherapy for ovarian cancer is associated with many adverse side effects. Those of you who've had chemotherapy know, and these are usually managed by the medical oncologist or the gynecologic oncologist. But the palliative care people, maybe they're one and the same or maybe not. They can focus less on whether the disease is progressing and more on how can we control these symptoms that are really bothering you. Much of the time, patients are reluctant to tell their surgeon, their gynecologic oncologist or the medical oncologist that something's bothering them. You know, people say to me, oh, you're too busy. You have so many patients to see. I don't want to bother you with that. You know, they'll tell my nurses things that they won't tell me. So again, it's trying to kind of get at what can we do to make our patients' lives better. Recurrence of ovarian cancer, when it does recur, it's often associated with a big decrease in the quality of life. Patients know that their time is more limited once they're diagnosed with a recurrence. And so this brings on many issues, both physical issues, emotional issues, and psychological issues. So physical symptoms. Pain and fatigue. Fatigue is one of the big things that my patients complain about. And, you know, patients say to me, oh, I don't want you to think I'm complaining, but I'm so tired. Loss of appetite, nausea. Many of our chemotherapy agents are associated with nausea. Everybody doesn't get nauseated, but many women do. They may have shortness of breath if they have fluid in their lungs. They may have problems with insomnia, which are associated with some of the medications that are used to pre-treat and post-treat chemotherapy. Many of these can be relieved with medications or using other methods, nutritional therapy, physical therapy, deep breathing techniques. These are some of the things that are available to patients. Chemotherapy, radiation, and surgery may be used to shrink tumors that are causing pain and other problems. So sometimes we use it in the palliative sense because we want to decrease the symptoms. So palliative care doesn't mean no treatment, but it really means treatment that's focused on symptoms. So what about symptom management? Intractable nausea and vomiting associated with chemotherapy. I've had a number of patients who had really significant side effects, and I think that involving people with expertise in palliative care would really help this. Neuropathy, that's one of the side effects of Taxol, one of the chemotherapy agents we typically use. And for many women, this is progressive and disabling. There's a lot of medications that can be used to improve neuropathy. There's a lot of medications that can be used to help not really prevent, but prevent a lot of the symptoms. Many times women will present with a bowel obstruction. Sometimes this can actually be treated medically rather than surgically. And there's different medications that can be used. Sometimes a surgeon may think that surgery is the only approach, but in fact, there's many other ways to treat these bowel obstructions. fatigue is one of the things that patients really, really complain about. And so there's a lot of things that we can do to help fatigue. There's antidepressants that help fatigue. There are some of these new medications. TRH helps fatigue. This is one of the drugs that's being studied here. Sometimes it's anemia that causes fatigue, and we can treat the anemia. Depression, which is often associated with the fatigue. Most women with ovarian cancer will suffer from depression at some time in their treatment. And so this can be treated, again, to improve their quality of life. Emotional well-being. This is not something that people talk to their oncologists about. Palliative care specialists, particularly people in the team, the psychologists, the social workers, they can really provide resources to help patients and families deal with the emotions that come with a cancer diagnosis and also with the debilitating side effects of a cancer treatment. Most patients are depressed at some point. They have anxiety. They're afraid. Only a few of these concerns, these are only a few of the concerns that can be addressed through palliative care. And oftentimes people, again, they don't want to bother their oncologist. Palliative care groups have experts that provide counseling. They can recommend support groups. This is something that helps women and their families a lot. They often will hold family meetings, again, to talk about, you know, where are we, what are the things that are important to you and your family. If the depression or the anxiety is so severe that they need mental health professionals, they can make a referral. Many of the hospitals, many of the cancer centers now have support groups, and this is another type of palliative care. So patients know that they're not alone. But again, these are some of the things that can be encouraged. Some of the practical concerns. Often patients and their families have financial and legal worries. They have insurance questions. They have employment concerns, concerns about completing advanced directives. For many patients and their families, the language is difficult. There's all kinds of legalese that may be hard to understand. The palliative care team can actually assist in coordinating appropriate services so that, for example, patients can keep their benefits. Patients can be sure that their insurance will cover their care. They can be sure that if there's legal things that need to take place, they can get help with that. They can get financial counseling, understanding medical forms or legal advice. They can identify resources or provide transportation or housing agencies so that patients and their families can get closer to their care. And then with spiritual concerns, again, this is not something that most oncologists are necessarily comfortable with, but oftentimes patients and families look more deeply for meaning in their lives. And, you know, one of the things that I have patients tell me is after their cancer diagnosis, they looked at life entirely differently, that it was a wake-up call, that, you know, it gave them a chance to really think about what was important to them. Some find the disease brings them more faith, closer to their church or whatever faith that they're involved with, and some patients question their faith as they struggle to understand why did it happen to me. Part of what can be done with a palliative care team is they can help patients and their families explore their beliefs and their values. And really what we want, as when I put on my palliative care hat, is we really want to help patients make decisions that are right for them. Is there any research that shows it's beneficial? It's an important question. Palliative care and its many components, there's certainly significant evidence that it's beneficial to patients and their family. A number of studies have shown that actually patients who have their symptoms well controlled are more likely to have a better experience with their medical care. Their quality of life and their physical symptoms will actually improve. The Institute of Medicine in 2007 reported in cancer care for the whole patient. There were many studies that had come out that showed that patients are less able to adhere to their treatment and manage their illness when they have physical and emotional problems. And particularly if patients have significant side effects. I've had patients come in and say, I can't do it anymore. And so one of the things that we try to do is sit down and say, okay, what is it that you can't do? What is it that you are having trouble tolerating? And so by doing that, that actually improves their ability to stay on their treatment. So what are some of the things, and maybe, Sarah, you can make this available to people. How do you find it? So you should ask your oncologist for the names of palliative care and symptom management specialists. This is not asking for hospice care, but you can call hospice because often they can make a referral. Area hospitals and medical centers can provide information. I got on the website, the Center to Advance Palliative Care, and it actually showed it by state. It showed hospitals and organizations by state that provided palliative care. But I caution you because this is a relatively new area. And so when I looked some of these people up, these were not necessarily people with expertise in oncology palliative care. So I think that as more people develop expertise who are oncologists, this will actually expand. There's a second website, the National Hospice and Palliative Care Organization, which has a list of providers. And so these are, if your oncologist or your social worker can't make a referral, this is a place that you can find, potentially find someone who can help. So what are the future directions? I think that in the future it will be as much a part of our approach as curative care. And one of the things that I think we see now is that we see that oncologists don't want a palliative care person to meddle. That's one of the terms that I've heard used. And so we have to really retrain. We have to train patients, or inform patients, I guess, and kind of retrain some of the oncology people, which I think is happening. That the palliative care professionals are part of the team. And part of what we don't want as oncologists, we don't want to lose control of our patients because we want there to be enough communication that we all know we're all on board with the same goals. I think that more oncologists will be board certified in palliative care, so patients will have many more resources. We know that it's more cost-effective and efficacious than only focusing on curative care because, number one, patients are more likely to be compliant with their treatment. They will stay out of the hospital. They will feel better. They will be more likely to be able to return to work. So there's a lot of benefits to palliative care. And palliative care and curative care are not mutually exclusive. And that's really what I want to leave you all with today. So I'm glad to answer any questions. And I enjoyed putting this together, and I hope this was helpful.
Thank you, Molly. That was great. Very helpful. Great presentation on a really important topic. We do have a few minutes for questions here. One question that we got was about caregivers, and can palliative care help caregivers?
Absolutely. I think that what palliative care can do is it can help the caregivers know what to do when the patient is having problems. And that's one of the things that palliative care really focuses on. It focuses on working with the caregivers and the patients. So I think it's very beneficial for the caregivers because many times people end up in the emergency room because their significant other or their daughter or whoever is helping care for them doesn't know what to do. And it gives them someone to call.
Right, okay. I'm wondering if you could get into a little bit more of the nitty-gritty about how palliative care is delivered. Can you talk about how it might be delivered in different settings? Is it only inpatient? Can people receive palliative care as an outpatient? Obviously, I'm sure it varies place to place, but I'm wondering if you could just sort of talk about the different settings in which people can access this kind of care.
I think they can access this kind of care in any situation. You know, as an outpatient, what I foresee in the future is that part of the oncology team will be someone with palliative care experience, and so they would potentially meet with the patient when they come in for their appointments, or they would meet with the patient separately. You know, not unlike we have a nutritionist that meets with our patients, particularly patients that are having difficulties. And so it would be available as an inpatient or an outpatient. It would also potentially be available to a patient when they were at home.
Okay. One question about, from one person is, if the symptoms I'm experiencing from being treated for ovarian cancer are well controlled, would I still benefit from palliative care?
You know, I think that's a question that's a little bit hard to answer. Maybe, maybe not. It would depend on what was available. I think that patients that aren't doing well definitely benefit from palliative care. If someone is in treatment and doing quite well and has no concerns, and, you know, that might not be as helpful. I think that introducing that early on so that people have resources is what's really important.
Right. You mentioned a little bit about how palliative care is paid for. is something that is paid for, but if a person has private insurance, a physician can bill for it, and it would be covered that way?
You know, that depends on insurance. I think that's one of the questions that's going to be, I think, will be answered in the next. It really depends on where Medicare goes with that. Right now, Medicare will cover some of it. For example, if you see a palliative care and a nurse practitioner or a physician for palliative care, it can be billed to your insurance. If you see a social worker, that's really covered by the hospital or by your organization. So it depends on who you see as to whether it's billable or not.
Gotcha. One question that just came in, which I'm going to reword a little bit, what's the difference between a palliative care professional and a patient navigator? Someone wants to know.
That's a great question. So a patient navigator is, there's quite a bit of overlap. A patient navigator is someone that helps usually a patient that's initially diagnosed and tries to help navigate them through the system. Much of the time what happens is a patient receives a diagnosis, probable ovarian cancer, gets a referral to an oncologist. It may take 2, 3, 4 weeks to get an appointment. The navigator can help expedite that appointment. They can help make sure that they get into radiology in a timely manner if they need a CT scan. They can help make sure that they can find their way to the lab. They can help set them up with a social worker if needed. They do not have expertise in treating symptoms. So a navigator expedites treatment. A palliative care person really expedites symptom control and kind of managing the rest of your life.
Right. Okay. Perfect. One question is, do you have any tips for overcoming obstacles that a patient might encounter if they have an unhelpful doctor who has not yet seen the light and doesn't understand the value of palliative care team?
That's a tough one, because I think, I think it's work in progress. I think that as this is recognized as an important specialty, more and more physicians will be on board. Now, that doesn't help the person who has a physician that isn't particularly helpful. I think there's several things you can do. I think you can look for another oncologist. That's certainly an option. That's hard for people to do when they're in the middle of treatment. I think you can sit down and talk to your oncologist. I think you can ask to speak with a social worker. Usually, most oncologists have access to a social worker, and they may be able to help you and make a referral. Again, I think it's important for patients to talk to their oncologist. Some oncologists are too busy to talk, but I think that it's important that patients really encourage their oncologists to sit down and talk to them about their goals. And that may open the door to a referral for palliative care.
Okay. You alluded a little bit to the to research that has shown the benefits of palliative care. We just had a question. Recent study showed longer median overall survival in lung cancer patients who had received palliative care as compared to a control group. Do you think that this study and studies like this are helping increase the acceptance of palliative care by both oncologists and insurers?
Absolutely. And there was the thing that got me interested was about 3 or 4 years ago. There was a study that came out that patients with advanced pancreatic cancer lived twice as long if they had palliative care versus if they were being treated aggressively. And that really got my attention because there are similarities between pancreatic cancer and ovary cancer, and certainly lung cancer. Yes, I think it will become more acceptable. I think there will be more push because I think it actually, in the long run, it saves money and it gives people a better life, so it's a win-win all the way around. But yeah, I think, we don't have that data in ovarian cancer yet, but certainly in some of the cancers that are untreatable, we know that palliative care actually makes you live longer and live better.
Okay. I think maybe we will wrap it up there. So I want to thank Dr. Brewer again for an excellent presentation, and then I want to thank everybody for calling in today. Please stay tuned for details on upcoming webinars from OCRF, and take a minute to fill out the survey that will appear on your screen at the conclusion of this event. Your feedback is always very helpful to us. And for more information about OCRF, you can always visit our website at www.ocrf.org. So I want to thank you all and have a great evening.